Start the next session, that is on orbit and eyelid. I'm Dr. Deep Shekhar Das. I'm Assistant Professor of Ophthalmology at AIOS, New Delhi. I have with me Dr. Praveen Kumar Mongre. He's an experienced orbit and oculoplasty surgeon practicing in Delhi. So today we have a lot of people who are going to turn up, I think. And as of now, I have seen possibly 8 people have already come. So, however, the list is supposed to be of 16. Should we wait, sir, for some time, or should we start?
We can start because more papers may come by the end of the session, and we will be allowing them also.
Okay. So I would like to invite on the dais
this paper, this R.A. Lakshmi. I invite Dr. R.A. Lakshmi to present her work on the thyroid ocular axis, unraveling the complexities of vision-threatening thyroid disease. ये एक्चुअली अलग-अलग किया हुआ लिस्ट, ये लिस्ट है. अब इनके बाद में ये सब है.
Good morning. Let us hear the tapestry of troubles created by thyroid eye disease. This 66-year-old female who presented to us with bulging, blurring and redness, swelling in both eyes for 6-month duration. She was consulted elsewhere and diagnosed as thyroid eye disease, treated with topical medications and systemic steroids once in a week for 8 weeks. She was symptomatically better, but 2 weeks after stopping IV medications, her symptoms recurred. She is non-case of glaucoma for 7 years on anti-glaucoma medications. She was systemically evaluated and found to be hyperthyroid and started on methimazole. On ocular examination, her best corrected visual acuity in the right eye was hand movements and left eye was counting fingers at 2 meters. Color vision was 0 in 21 and 2 in 21 in right and left eye respectively. Pupils were sluggishly reacting to the light. Both eyes had significant inflammation with the proptosis, restriction of extraocular movements in all directions with a clinical activity score of 7 out of 7. In right eye, there was a corneal ulcer with exposure keratopathy in both eyes. In posterior segment, there was no view in the right eye, whereas left eye showed disc edema with these hemorrhages. We came to a diagnosis of active thyroid eye disease in both eyes with lagophthalmos, exposure keratopathy, compressive optic neuropathy, and corneal ulcer in right eye. Corneal scraping was done, which was positive for fungal hyphae. Culture yielded aspergillus species. MRI orbit showed fusiform enlargement of extraocular muscles with optic nerve compression. So we admitted the patient and started on topical and systemic antifungals. Single dose of IV methylprednisolone was given. Both eyes lateral canthotomy, upper eyelid blepharotomy, and tarsorrhaphy was done in sequential manner. On day 5, you can see there was improvement in inflammation, vision remained the same, and fungal ulcer was healing. Hence, we started on low-dose steroids and azathioprine and considered for endoscopic orbital and optic nerve decompression. On 1.5 months follow-up, patient had improvement in vision. The inflammation have reduced further. Disc edema was persisting. Here we stopped the antifungals and rest of the medications were continued. And we kept the patient under close follow-up. During follow-up, there was drop in vision. Hence, orbital radiation was given over 12 fractions. On 1 year follow-up, there was further improvement in the visual acuity with complete betterment in color vision. On 1.5 years, patient had again drop in vision, but now it was due to worsening of cataract, for which both eyes cataract surgery was done. So after cataract surgery, patient had excellent visual outcome with a 6.9 in the right eye and 6.6 in the left eye. Disc edema have completely subsided with the normal posterior segment. But once the vision was better, patient started appreciating diplopia. Squint evaluation showed restrictive strabismus in both eyes, for which medial rectus recession and inferior rectus recession was done in right eye as a first stage procedure. Here we can see on the 3-year follow-up, patient was doing well with no signs of inflammation and with a good vision. So to summarize, in case of active thyroid eye disease with compressive optic neuropathy and microbial keratitis, early diagnosis and aggressive management and team effort will definitely result in good outcome. Ocular surface protection, antimicrobial treatment and controlling the disease activity has equal and important role. So in thyroid eye disease, which involves complex inflammatory reaction, by several mechanisms, it can cause ocular surface instability and can predispose to microbial keratitis. So these are my references. Thank you.
Just one quick comment. In the meantime, next, please come. Who is there?
Ashwarya.
Dr. Abhijay Luthra. Dr. Abhijay Luthra.
I think she has a presentation which is uploaded. It seems. Dr. Aishwarya, in the meantime, I think can come.
Oh, Dr. Aditi has come. Dr. Aditi. Dr. Aishwarya. Who are you? Please come, please come. So just a quick comment for all. In case where the optic nerve is threatened, whether it is associated with any other complication, aggressive treatment is there. Fine, and as you've been taught properly, that it is intravenous methylprednisolone 1 gram on a weekly basis. And if it doesn't show a good response or adequate response on 3rd week, then decompression is taken up. And in the meantime, the conservative management like you have done. In your case, you did the decompression quite early?
No, sir. Patient have already received 8 weeks of IV
8 weeks.
methylprednisolone.
After
then,
8
then
weeks,
she came to us. So during that presentation itself, we gave a single
This
dose and then followed up with
this kind of acute presentation was after 8 weeks of the initiation of intravenous methylprednisolone.
Yes, sir. After taking 8 doses,
8
patient
doses.
was 8 doses. Patient was symptomatically better, but she had her symptoms later on. 2 weeks there was quite betterment in the inflammation.
Okay.
Was there any improvement in the vision per se? Vision in the sense, like I think initially you mentioned that the vision
It
was.
was hand movements
Yeah.
and counting fingers. From that 6/9 and 6/6 vision, sir. After the
that took
cataract
place
surgery.
after everything, right?
Everything, sir.
Okay. Was at any point of time afterwards color contrast or fields done up? Color, I think I mentioned previously.
Yes, sir. Color
But was
vision.
fields done? Because usually
yes,
optic
sir.
nerve gets all
Patient
involved
was
as well.
non-case of glaucoma, and the field was done after the improvement in the. Once the vision, the posterior segment view was better, we have done a field which showed arcuate defect, sir.
Achha, is it because of the lens or because of
Glaucoma test changed. So
Glaucoma
the
test
previously also patient had similar arcuate defects in both eyes.
Okay.
It was persisting after the treatment also.
Okay, very nice presentation otherwise.
Thank
The
you,
thing what I wanted to mention was that in case of thyroid eye disease, there is always a possibility of the muscles or even the fat. What they do is they, when they proliferate per se, they squeeze on the optic nerve. So optic nerve functions get impeded. That is when it comes to this side optic neuropathy. And when you're talking about vision, color contrast fields are the parameters. So even the field will get compromised.
Yes.
And if it's a reversible situation, where if you intervene very early, the field effect which was there previously, it will go away. So this arcuate thing, which was possibly because of glaucoma, maybe is because of a glaucoma thing, but patient did not actually have any major field effect because of the thyroid this side optic neuropathy per se. Anyways, good.
Thank you.
So that message is that for every thyroid eye disease case, along with vision, you record the OCT findings also and visual fields findings also pre-treatment and during the course of treatment to monitor. Thank you. Thank you. So Dr. Aishwarya, please. She is speaking on a case of infraorbital schwannoma when the tumor chooses to arise from somewhere else.
Good morning, everyone. So introduction about schwannoma is that it's a benign encapsulated tumor originating from the proliferation of Schwann cells of myelinated peripheral nerve sheaths. Incidence of malignant transformation of this tumor is less than 1%, and it is associated with syndromic disorders such as neurofibromatosis type 2, Carney complex, and schwannomatosis. Infraorbital schwannoma is a rare benign tumor originating from infraorbital nerve, which is a first branch of trigeminal nerve. It can manifest as a slow growing mass in the cheek region. So about the case, a 46-year-old male presented to the Squint clinic with complaints of outward protrusion of right eye since 6 months, insidious in onset and gradually progressive, painless. Previous CT orbit done elsewhere showed evidence of pseudotumor and lymphoma, and hence was referred to a tertiary center. Patient is a known case of hypertension since 5 years on treatment, and family history and systemic examination, nothing was significant. The visual acuity was 6/6. Color vision, extraocular movements were within normal limits. Ocular posture had 15-degree exotropia. Anterior segment was within normal limits. On inspection, there was axial proptosis. On palpation, fingers were insinuated between globe and orbital rim, and tenderness was present laterally. On exophthalmometry, palpable fissure vertically on the right eye it was 11 mm, horizontal measurements were 33 mm, and axial measurements was 24 mm, vertical measurement was 24 mm. This is the pre-op photo of the patient. The first photo, it shows axial proptosis. The second photo is of the axial section of CT orbit, which shows the hyperintense lesion which is present inferolaterally, somewhere between the inferior rectus and inferior oblique muscles. This sorry. So the initially the during transconjunctival approach was made, and tenons was dissected inferiorly. The inferior rectus and inferior oblique muscles were identified, and between the orbital rim and the inferior rectus and inferior oblique muscles, the tumor was identified, and through blunt dissection, the tumor was excised. Grossly, the tumor measured around 30 into 1.5 mm, and on histopath, it showed biphasic appearance of antony A and antony B cells, which were spindle type cells of hypercellular and hypocellular in nature. What was unique in my case was that lesions in head and neck region account for 25% to 45% of extracranial schwannomas, but it rarely involves trigeminal nerve and its branches. So clinical implication could be we can consider schwannoma as a differential diagnosis for this, and orbital schwannomas usually present as painless proptosis. The chances of recurrence, intracranial extension, and malignant transformation are higher if the tumor is highly cellular on histology or wherever the tumor is removed piecemeal. So the tumor might progress on to pressure effects such as papilledema or optic nerve atrophy or retrobulbar neuritis if not presented sooner. So use of various imaging modalities plays a key role in the diagnosis before surgical excision. Thank you.
Very nice presentation, Dr. Aishwarya.
Thank you.
So, any comments, sir?
Yes. From which institute you are, please?
Minto Eye Hospital, Bangalore.
Okay. Because this is a postgraduate's session, when you were doing the orbitotomy, transconjunctival route, the surgeon was putting fingers again and again inside. So we normally try to avoid this because it has to be under direct visualization, hand-on-hand technique, and not the blunt surgery. But still good. Thank you very much. Thank you. Anything you want to add? No?
So, anyways, I will just like to add, we also do use our fingers a bit when it comes to the surgery. Though, I'm not just contradicting it. Just in few cases we do, because in transconjunctival, it's many a times it depends upon the plane of the lesion. We also do it.
It is always better to be directly looking at what you are doing, since you have access to microscopes, fine and good instruments. Always, but I'm just feedback to the postgraduates
that you should directly visualize
directly visualize what you are doing.
One point I wanted to add, because when you were mentioning about exophthalmometry per se, you mentioned multiple things. You didn't mention the base prism, you will use the Hertels, right? Or use some other. And when you're talking about Hertels, we talk about just the axial proptosis. You have mentioned about vertical as well as axial proptosis. Vertical, how did you measure vertical? We usually don't measure. We just do ideally you're supposed to use scales for measurement of palpebral apertures, not just Hertel's exophthalmometer. It's just for the axial proptosis which is readily used.
So what he means to say is that it's an abaxial proptosis. Hertus is not the instrument to be used.
Okay, sir.
That's what he wants to say.
Okay, anyway, it's a very nice presentation.
Thank you.
We can move on to the next presenter, Dr. Pooja Mahesh Rathi. In the meantime, is Dr. Alisha Siriskar, Dr. Anupam Singh, or Dr. Aravind here? Yeah, Dr. Aravind is here. Okay, you have given your slide. Maybe next time, next you can. So Dr. Pooja will be talking about a sweet story. Trauma is area full of surprise. Okay, you don't need to mention that. Pooja Mahesh.
A very good morning. I'm Dr. Pooja Rathi from Sri Ganpati Netralaya, Jalna, and I'll be presenting a sweet story. Intraorbital foreign bodies are now on a rise because of the mechanized and violent nature of our society. It can have range of symptoms, right from vision loss to even life loss. Decision to explore or to observe should be very clear among the minds of ophthalmologists. Here is one such case. A 36-year-old gentleman resident of Jalna got hit on a sugarcane trolley. Sugarcane went and stuck inside his left eye. He had an episode of nausea and vomiting and a suspected head injury. An attempt to remove the foreign body elsewhere collapsed the patient. He was kept under observation for 12 hours and then referred to us for eye injury. He had decreased vision, PLPR accurate, severe pain on attempted ocular movements and even limitation of movements. He had conjunctival chemosis and congestion and intermittent nasal bleeding. We explained the condition to the patient and relatives and an urgent need of imaging of the orbits. CT orbit axial coordinate sagittal, 2 mm cuts with bone windows with brain screening was done. A large wooden foreign body in the inferior orbit, 27 mm into the orbit from the skin surface, just short of the apical structures, inferior to the optic nerve, with query transection of the inferior rectus and blowout fractures of the floor and medial wall was seen. The foreign body was indenting the globe from the inferior side and there was no obvious globe injury. So our plan was to explore and to address each component accordingly. With the help of dissectors, we started dissecting the foreign body. The foreign body was not coming out easily. On further exploration, we found that the foreign body was stuck between the sheets of the inferior rectus and inferior oblique. So we lateralized the inferior rectus muscle and then started removing the foreign body out. All the residual pieces of foreign body were removed, a thorough antibiotic and NS wash was given, the inferior rectus which was transected was sutured with 6O Vicryl and the wound closed in a layered manner. This was the foreign body. This was the pupil immediate post-op, round, reactive to light. The vision was restored back to 6/6. The EOMs were full and free. There was no diplopia and just mild in ophthalmos. This was our sweet story of sugarcane. We hereby report a very atypical presentation of intraorbital wooden foreign body inferior to the optic nerve, just short of the apical structures and encased within the sheets of inferior rectus and inferior oblique. Only with thoughtful planning and thoughtful intervention, we could give the best possible results. So organic foreign bodies should always be removed. Inorganic foreign bodies, if anterior, can be removed. If posterior, should only be removed in case of infection, inflammation, and functional deficit. Our take-home message: trauma is an area full of surprises. Imaging and reading the films yourself definitely makes a difference. Beware of the orbit. You can find in anything on the earth. I thank my guide, Dr. Mangesh Thobekar sir, for guiding me. Thank you.
Yeah, a very good presentation. Yeah, ma'am, you'd like to pick up.
So, nice presentation, Pooja. Actually, you know, the area where your foreign body was lodged, it's very common location for any long foreign bodies. Like even knives I've seen getting lost there with intact visions.
Oh, wow.
So, what is the take-home message is that you did a very good job, definitely, and you're lucky that your actually vision is intact, but it may not be the case always. And in fact, the very fact that on table you will see signs of RAPD and all those things where you would see the urgency of intervention. The second thing is your story is not over yet, because these foreign bodies, especially wooden foreign bodies, they may have multiple small pieces which may be there. Right. And post-operatively, you must get an MR, no CT now. you must get an MR to check whether you still have any leftover organic foreign bodies, which may again you need to go back and remove. Second thing, not all metallic foreign bodies, simply you don't wait for inflammation. If it's an iron foreign body or copper foreign bodies, then they have to be removed, even if they are lodged posteriorly. Thank you so much.
Thank you, ma'am.
Same I would like to add on. Like you said that all foreign body pieces were removed. This all can never come, because we always find, or because it's very difficult, especially for the wooden foreign bodies, and especially these type of wood where chips are common, like this sugar cane or bamboo sticks, where the chips, small chips, which keeps on lodging inside. So can you recollect what is the longest follow with this patient?
Sir, he had come after like 1 year also. He had come like post 1 year.
I mean, you are lucky, but for all the residents, the wooden foreign bodies have to be managed as soon as possible and thoroughly washed, so that you are sure, at least you are sure that you have removed all. Thank you. Anything you want to add, sir?
I have this question for the panelists. So, what is your take on giving antifungals for such scenarios? Prophylactic?
No.
You usually don't. Right? Okay.
Not
Because
orbital, I don't.
Okay.
If it's intraocular, then things are totally different.
Okay. Thank you. Very good presentation. So next up, I think Dr. Anupam Singh. Anupam Singh, right? Arvind Krishna. Yeah, please come up on stage. He will be talking about recurrent retinoblastoma. Oh.
Good morning, everyone. Good morning, judges. So today, I'm here to talk about a case where there was an unusual recurrence of a tumor whose story we thought was over. So sometimes we all try to forget our past, but our past may not always forget us. So this case is titled Echoes from the Past. So the tumor in question is retinoblastoma, which you all know is the most common pediatric ocular malignancy. It is triggered by mutations in the RB1 gene. It can either be familial or the much more common sporadic one. So most commonly, it can present as leukocoria or strabismus, and other less common symptoms are red eyes, poor vision, heterochromia, hyphema, and it can also be asymptomatic. So retinoblastoma is usually a clinical diagnosis, and ocular imaging such as B scan or MRI can also help, and it is a multimodal treatment approach, and genetic screening is also very, very important. So we talked about retinoblastoma. So coming to our case, so this was a 20-year-old female who's a known case of bilateral retinoblastoma. So she was diagnosed as a child back in 2005. So CT scan done in 2005 was suggestive of bilateral retinoblastoma with optic nerve head infiltration. Bone marrow aspiration and lumbar puncture done at that time was negative. So subsequently, the patient underwent 9 cycles of chemotherapy, the last cycle on 18th of April 2006. Following the treatment, the tumor had successfully regressed, and the patient had been prescribed low vision devices and was on regular follow-up. So the patient from 2005 until now was symptom free, as in there was no new symptoms. So the patient's vision as on 31st May of 2024 was 660 in both eyes. So now what happens? She comes to us on the 25th of November 2024, which is 20 years from the point of diagnosis. She came with complaints of defective vision in the right eye for the past 6 weeks. And as you can see, the vision in the right eye dropped from 6/60 to half by 60. On evaluation of the fundus, we saw that there was a reactivation of retinoblastoma at the edge of the prior calcified lesion, as you can see on the image. A diagnosis of a recurrence of retinoblastoma in the right eye after 20 years was made. So the patient was then managed with transpupillary thermotherapy and intravitreal topotecan, followed by systemic chemotherapy with the vincristine etoposide carboplatin regimen. And thankfully, the patient's vision improved to 5/60, and the patient is now on regular, more constant follow-up. So what is unique of my case is that usually a recurrence in retinoblastoma can occur within 2 to 3 years after treatment completion. That is a common story in many patients. But this patient had a recurrence after 20 years. Such a late recurrence of this tumor is rarely ever been reported. So, what are the clinical implications? Bilateral or heritable retinoblastomas, especially with those with RB1 mutations, can have recurrence at any point in life. And hence, a continuous follow-up is very, very important in these cases. And there's also a probability and a high risk for secondary malignancies in these patients, such as osteosarcoma, re-wings, and you should always be on the watch out for those. So the final take home is that a long-term follow-up is needed for retinoblastoma cases with RB1 germline mutations, and early diagnosis and management can have a favorable prognosis. I would like to thank Dr. Usha Kim for giving me this case.
I have to ask a question.
Yes.
What has been the reason for low vision in this child for so many years, and what was the reason for sudden drop of vision?
Sir, the low vision was probably due to the tumor and the subsequent chemotherapy, the residual damage which the tumor left following its.
What was maculopathy?
Yes, sir, there was.
Neuropathy. What was there?
There was a maculopathy.
Or amblyopia or what?
It could be attributed to amblyopia. So there was the residual scarred lesion in the
month of May when the child came with
yes,
560 or 660 vision.
Yes, sir.
That time thorough examination was done. Everything was done.
Thorough
OCTs,
examination.
OCTs, etc., etc.
Yes, sir.
Or it was just a clinical checkup.
It was both a clinical and B scan and imaging was done.
Was there a change from that to the next presentation when she came with the half 6/60 vision?
Yes, sir. On the presentation on May, there was a calcified lesion which suggestive of the old retinoblastoma. The image which I've not yet put here. But in November, the image showed a reactivation of the tumor in the prior calcified region. So in May, there was no new lesion. There was just a scarred lesion.
On ultrasonography?
The
scan change?
Yes, the scan showed the tumor, the new tumor from the prior edges.
Now, how this tumor affected the vision? That is what I'm asking. The reactivation affected the vision.
It probably would have encroached more on the macular area, sir, and causes decrease in vision.
Actually, what sir is trying to say is that the lesion, what we could see, was not affecting the macula. It was just lying inferior to the macula.
Okay,
so
sir.
possibly he was expecting a better vision from that patient. That's what I'm getting.
That's what I'm saying. But is initially why the vision is so poor, and then drop in the vision, because follow-up means follow-up. She has been regularly following, means we okay anyhow.
Okay. One question, like why was intravitreal given?
Intravitreal topotecan was given.
Why was it given? I could not see any obvious seeds per se. So is it a routine thing which is done in your setup?
Yes, sir. In our when I spoke to the retina consultants, they told me the routine focal therapy of transpupillary thermotherapy with intravitreal topotecan is followed. Is what I was told.
As per the international norms, it's given purely just for the vitreous seed. It's not for this. And we usually give for. Had this been the patient had bilateral but activation in the one eye, right?
Yes, sir. Yes.
Okay. Why was not IAC even considered?
Which one, sir?
Intra-arterial chemotherapy for this patient.
It was sir, bilateral retinoblastomas.
One is already you have mentioned that regressed, and also we have tandem therapy as well if you want to. In the present day scenarios, okay. Anyways.
Yes, sir.
Yeah.
Thank you.
Okay.
Who is the next in line?
Next, I think we will have Dr. Punya Muralidhar.
Good afternoon, everybody. Good afternoon, everybody. Today I'm going to tell you about an eyelid itch which turned costly. So there is a 57-year-old female who presents with a complaint of itching in the right upper eyelid for since 6 months. It was associated with mild redness and loss of lash, but there was no history of any allergies. She was diagnosed and managed outside as recurrent blepharitis since a long time, but there was no resolution in any symptoms. When the patient presented to us, there was loss of lash in the right eye with erythematous skin around the lashes. There was also a mild distortion of the lid margin which was present, along with a mild thickening, and on inversion, we could see congested palpebral conjunctiva. So at this point, our differentials were either a chronic blepharitis, which is refractory to treatment because of the itching and erythema which is present, or it could also have been a more sinister presentation. There is a sebaceous cell carcinoma due to the age group of presentation and the location on the upper lid. Plus, there was also a distortion of the lid margin. So we went ahead and did a biopsy, and surprisingly, we found numerous epithelioid cells and Langerhans giant cells, suggestive of a non-cageating granulomatous inflammation. So now our differentials became tuberculosis, sarcoidosis, Wegener's granulomatosis, or a fungal infection. But asking the history, there was no history of any rhinorrhea or hemoptysis and no necrosis found on the histopathology. So we thought that Wegener's was less likely. Plus, in an immunocompetent person with a fungal stain negative on histopathology, fungal infection was also deemed unlikely. Yet we did a whole battery of systemic investigations for the patient, but only abnormal values were the ESR, which was raised, the chest X-ray, which showed bilateral asymmetrical hilar lymphadenopathy, and the Montauk's test, which was positive. So seeing this along with the normal serum calcium and serum ACE levels, our first suspicion was the tuberculosis, because as we know in India, everything is TB unless proven otherwise. So we did a repeat biopsy for the TB gene expert, but that was also negative. So now we were utterly confused, and we asked the pulmonology department for our last hope. So they asked the history of the patient again, and there was some dyspnea on exertion. So they did a pulmonary function test, which showed a mild restrictive lung disease. So now we were getting somewhere. We got an HRCT test done, where it showed ground glass opacities with bilateral micronodules and a thickened septa. So further on, to confirm these findings, we got a biopsy from the mediastinal lymph nodes, which showed non-caseating granulomatous inflammation. Hence, a diagnosis of sarcoidosis was made. The patient was started by the pulmonologist on tablet prednisolone 1 mg per kg per day, which was tapered by 10 milligrams per week. And on 1 month, we found that there was no itch at all. There was decrease in redness, decrease in the lid swelling, even few lashes had regrown, and the pulmonary function tests had improved. And this magical response to steroid also supported our diagnosis of sarcoidosis. Sarcoidosis, as we know, is a chronic, non-cageating granulomatous multisystem inflammatory disease, while ocular involvement is only seen in 20 to 30%, most commonly being uveitis. However, sarcoidosis of the eyelid is a rare entity, which may include the specific millet seed-like nodules, ulcerative nodules changes. There is no single gold standard test for diagnosis of this disease, but the American Thoracic Society says that any compatible clinical radiological finding with the histological evidence of a non-necrotizing granuloma, and after ruling out other granulomatous causes like we did in our case, we can reach to the diagnosis. For the treatment, we usually start with systemic, topical or intralesional corticosteroids, and in resistant cases, immunosuppressant therapies have also been tried. After the active inflammation has been resolved, we can go ahead with surgical reconstruction if there is any cross distortion. So my take-home messages from this would be, first of all, never ignore even a simple history of itching inside a patient. Second, an eye can tell us a deeper story about the body, and that is our duty to reveal for the patient. And third, sarcoid can never stop amazing us, be it as an MBBS student or even as a postgraduate. Thank you so much for listening. It was indeed a costly itch.
For the postgraduates, this is exactly the way these cases are managed, exactly in the same way, whether isn't it? And role of pulmonologist, because they can take the biopsies, and that clinches the final diagnosis. Thank you very much. Thank you.
So I think the take-home message would be that any of these patients, you should not, if it's a chronic blepharitis not responding, you must try and make a definitive diagnosis and take biopsies. So this is one point which you have really highlighted well. And the other thing is, I'm a little surprised that the first instance, why didn't you get in, your HRCT did not pick up those findings in the first instance itself? Why was the confusion?
X-ray done only.
Yeah, so another take-home message is that X-ray chest again is not, it's just a screening tool. Lots of these findings may be missed by an X-ray
was
chest.
positive, so they did X-ray chest only.
Yeah.
And later on, she subjected
And
it to CT scan.
sarcoidosis usually don't have a strong mount, the Montus being maybe, again, these are all not very reliable, investigations. You have to corroborate each and everything, and whenever in doubt, always go for an HRCT, not X-ray. Yeah. Thank you.
So, do you have Dr. Sama or Dr. Ankita? Next up, we have Dr. Saurav De, who will be talking about orbital myiasis. Saurav.
साल में 1-2 तो आ ही जाते हैं ऑर्बिटल सर्कॉइड के ना.
Good morning. Myself, Dr. Saurabh De. I am going to present on the topic of invasion of the orbit, the uncommon tale of orbital meiosis. We all know that meiosis is the infestation of living vertebrate animal tissues by larva maggots, and less than 5% of human meiosis involves the eye. Involvement of ocular structures by larvae of dipterous flies is widely known as ophthalmomyosis. There are lots of parasites are there, like hypodermy bovis, ostrea ovis, like that. They can infest human body. So in our case, a 61-year-old diabetic patient presented with the history of ocular injury followed by non-healing ulcerated area at the lateral canthus of her right eye since 2 years, along with bleeding and foul-smelling discharge. Recently, she presented with generalized periorbital edema with matting of eyelashes, and severe conjunctival congestion was there. An ulcerative lesion was noted at lateral canthus of right eye with foul-smelling discharge. And we have seen small freely moving maggots were visible in the wound, but no intraocular involvement was noted. After the proper investigation like slit lamp examination and fundus examination of the other eye, that was normal. Now for the affected eye, we have done CT scan brain with bilateral orbit with 3D reconstruction that shows that the soft tissue swelling of right orbit with extension to right temporofrontal area, and MRI is also done. The shape of the right orbit eyeball was changed. So after installation of ether, 47 maggots were removed and regular dressing was done, and most importantly we have given tablet ivermectin 12 milligram since dose given, and 1% ivermectin drop prepared by dissolving the tablet in distilled water. Now entomological evaluation reveals the specimen content larva of Lucilia sericata, and histopathological examination suggested that there is a basal cell carcinoma due to trauma. Now here are the photographs. At the center we have seen that is the infested area in the right orbit, and CT scan showed there is a swelling, and the CT scan of 3D reconstruction showed there is destruction in the right orbital area. And at the right top there is the collected maggots, and lastly there is in the pathological slide there is some basaloid cell and palisadic manner that give rise to the conclusion of it is a basal cell carcinoma. Here I am removing the maggots with forceps. Here we can see the rolling motility of the larva is seen. So why it is unique? Orbital meiosis is very rare. Only 2 to 3 case presentation are seen in the eastern India, and there is a severe infestation of 47 maggots were seen, and after the chronic debilitating some conditions like trauma, diabetes, it can occur. So what is the clinical implication from my study? That chronic debilitating conditions like leprosy, diabetes mellitus, open wounds can cause the maggot, and early intervention is needed. So we should know that prompt diagnosis and aggressive management are essential, and awareness of risk factors can help in prevention, and regular follow-up is needed. I sincerely acknowledge my mentor, Dr. Professor Sanjoy Kumar Daulat Thakur sir, and this is my references. Thank you.
Can you show the clinical photograph once again, please?
Yes, sir.
This tissue for biopsy was taken from where?
From after removing all the maggots from the base of the infected area, we have taken the biopsy.
And margins of this ulcer?
Yeah, it was also taken that the margins and the infected area was taken, and from the marginal area it goes a rolling margin like that.
No, you have taken an incisional biopsy, or you have excised everything? What have you done?
No, in our college there is no any oculoplasty department, so we have sent the patient to plastic surgery department. They had debride the lesion, and from that excised biopsy was taken.
Because there is an orbital invasion also.
Yeah, orbital invasion was also there.
So do you have some post treatment photograph?
No, actually
For basal cell carcinoma,
Yeah.
what further has been done? That is what I'm asking.
for basal cell
Maggots is fine. Fine, maybe there was small ulcer at some point of time, it got infested and it became a big ulcer. Fine, and then you have proved it that it is a basal cell carcinoma. Fine, what further has been done?
As in our college, there is no any
So
oculoplasty
you must
department.
have
We have
knowledge, no, since you are presenting this case. Fine.
Extension of the area should be done.
They should
No,
be.
no,
What
no,
have
no.
you done? Have
So
you?
he doesn't know.
Acha.
Followed up with you. That's
Have-
what he's
No,
asking.
no, no. So missed
Once the
follow-up.
diagnosis has been made and
After
maggots have been
she was
managed.
admitted in our department for 1 month, then we have regularly dressed up, and then we have referred the case to our plastic surgery department. The exenteration was done, and then referred to higher center.
Exenteration.
Yeah, so removal of the tissue was done. Then the
Excision.
she was then
So I
refer
think
to-
let's let's summarize this. So you may have orbital these biases and these infestations in any patients where you have a neglected malignancies like basal cells especially is neglected because it's a slow growing ulcer, doesn't bother the patient. So people just take it in their stride key. This is a common accompaniment and nothing much to be done about it. The second thing is, of course, if the patient is immunocompromised, you can get these kind of infections. And the most important part is that I think 1 month was not justified to waste just to remove the maggots and all that. What the take-home message, what Dr. Mongre was also trying to emphasize is the definitive management. If you can see, look at the scans, the mass is not just limited superficially, it's infiltrating deep down. So something urgently needs to be done about it. So that is the most important part of this whole story. So anyway, very nice presentation.
thank you, ma'am.
Very good.
Thank you, sir.
So next up, I would like to call on the dais Dr. Supriya Jayagopal. She'll be presenting a case of ancient schwannoma. Is she here? Yeah. Next presenter will be Dr. Jayashree Chitti. Please be ready.
Good morning, everyone. I'll be presenting a rare case of intraorbital nerve schwannoma causing proptosis. Orbital schwannoma is a rare type of peripheral nerve sheath tumor that arises from hyperplasia of myelin-producing Schwann cells and varies in clinical presentation. About 1/3 of schwannoma cases occur in the head and neck area. It is also known to originate mainly in the auditory nerve. However, orbital schwannomas are rare and account for 1 to 4% of all orbital tumors. They are usually solitary with well-defined margins and usually presented with slow, progressive and painless mass which can cause ocular proptosis. In this case, we report a rare, benign, isolated case of schwannoma arising from the infraorbital nerve in a case who initially presented with a painless unilateral proptosis. Case details. Here is a 40-year-old man with a unremarkable systemic history, presented with outward protrusion of the right eye since 3 years, gradual in onset and progressive in nature, not associated with pain, diminution of vision, redness, double vision, inability to close the eyelids, and with no history of trauma or ocular surgeries. On examination, the right eye axial proptosis was noted with no visible orbital swelling or mass, no visible pulsation with normal skin of the eyelids. On palpating, fingers can be insinuated between the globe and the orbital rim, and no tenderness was noted. On the retropulsion test, the resistance was felt on pushing the globe backwards. On measuring the palpebral aperture, using a Hertel's exophthalmometer, the axial measurements were 35 mm in the right eye and left eye it's 20 mm. MRI orbit was ordered that revealed a well circumscribed ovoid right intraorbital mass of 35 into 19 into 16 mm of intraconal location in the inferomedial quadrant, displacing the optic nerve superomedially and ocular globe anteriorly. It elicits an intermediate signal on T1 and high signal on T2 and flare with progressive and heterogeneous enhancement on post-contrast sequences. A provisional diagnosis of infraorbital nerve schwannoma was made and a surgical plan of tumor resection through the inferior transconjunctival fornicel approach under GA was planned. A well encapsulated grey-white mass was removed and sent for histopathology, and the patient withstood the procedure well. Histopathology confirmed the diagnosis of ancient schwannoma showing Antony A and Antony B bodies. This is the MRI imaging. The first image shows a T2 image having a heterogeneous enhancement, and the second image showing T1 having a microcystic changes on T1, and the sagittal section shows coronal section shows intraconal location of the tumor, and as well as the coronal section, sagittal section, sorry. This is the intra-op picture. The first image is showing the intra-op picture of intraconal shape, cone-shaped mass, and histopathology showing compact Antony A cells and the loose Antony B area, confirming the diagnosis of schwannoma. On post-op day 1, the patient vision was 6/6 with normal color vision and contrast sensitivity. He had lid edema with conjunctival congestion. 1 month post-operatively, he had no recurrence but had right eye exotropia with no diplopia or limitation of extraocular movements and mild tingling sensation over the right cheek. What is unique in my case was infraorbital nerve schwannoma usually presents as a nodular cheek swelling, but this case reports as an orbital schwannoma. Prolonged progression of proptosis without visual loss or pain is unusual. Many orbital tumors present with acute symptoms or earlier visual impairment. MRI describes a well-circumscribed ovoid and encapsulated mass which characterizes schwannoma. The tumor's location in the intraconal space, displacing the optic nerve superiormedially, poses a challenge. The preserved vision postoperatively indicates that tumor grew slowly without compressing the nerve. The histopath strongly confirms schwannoma but is less common in orbital cases. Clinical implication, prolonged painless proptosis requires detailed evaluation and raises suspicion of slow-growing orbital tumor. The tumor's proximity to the optic nerve requires a thorough surgical planning to avoid damage and reduces post-operative complications. Schwannoma is a benign tumor with minimal risk of recurrence if completely excised. A combined imaging and histopath aids in appropriate diagnosis, and regular post-op monitoring is essential to detect any complications or regrowth of the tumor. Take-home message, the combination of prolonged symptoms and preserved symptoms, despite optic nerve displacement and characteristic histology, makes this a unique case. Imaging is a key to diagnosis and surgical planning. Early diagnosis helps in planning an effective surgical approach, as orbital schwannoma can mimic other orbital tumors, and infraorbital nerve schwannoma can be a differential diagnosis in cases of slow progressive non-inflammatory proptosis. No financial interest, and thank you.
So nice presentation, a very typical schwannoma case. Just if you look at your scans, MRI, Dr. Praveen was just discussing, you look at those scans and that schwannoma is going to tell you I'm a schwannoma. So if you can just put on your scans again, you just see a very well circumscribed mass with just central, that variegated appearance that will pick up, clinch the diagnosis. Of course, the definitive diagnosis is your histopathology. The second thing is you should remember that nowadays we all are trying to go for minimally invasive surgeries. So what is important is don't breach the capsule, take it out in totality. So that is another take-home message, and most of these patients do very well. In fact, it's a nice tumor for an orbital surgeon, very nice, easy to take out. So you can just see in the center, just center that mark, that area, can you see those typical, so that's exactly what a schwannoma would look like. There is a peripheral enhancement, and in the center you can see those areas. So all schwannomas, more or less, they look like this. Thank you.
Very nice presentation. So we'll move on to the next presenter, Dr. Rajeshwari Chitti. She will present a case of ocular cysticercosis. In the meantime, Dr. Tisha Vasant should be ready for the next case.
Good afternoon, everyone. Myself Rajeshwari Chitti. I am going to talk about a case of ocular cysticercosis, an uncommon vision threat. So coming to introduction, ocular cysticercosis is a preventable cause of blindness, and it is caused by larval form of Tinea solium, cysticercosis cellulosae, and ocular adnexa is noted to be the most common site of disease in India, and posterior segment being one of the most common site of the infection. 35% cysts were found in subretinal spaces, 22% in the vitreous, 5% in the anterior segment, and 1% in the orbit. So when extraocular movements are involved, superior rectus is most common site, and cyst reaches the subconjunctival space from the adjacent muscles. So coming to the case, here the 25-year-old male patient by laborer by occupation and resident of Uttar Pradesh came with the chief complaints of swelling, redness, pain in right eye superiormedially since 1 month, and he complains of redness and pain in right eye since 15 days, and he also gives a history of fall of dust particles into right eye 1 month ago, following which swelling developed. And on examination, visual acuity in right eye was 612 parts partial, improving to 6.6 on pinhole. And on slit lamp examination, the swelling was located superomedially, measuring 1 into 1 centimeter approximately. It was soft in consistency, tenderness was present, skin over the swelling was normal, and lid edema and ptosis was also present in right eye, and associated with conjunctival congestion. And other rest of anterior segment was normal, and fundus examination was normal, and left eye visual acuity was 6.6 and rest anterior segment and fundus was normal. And patient was planned for excision biopsy of right eye, but on table the cyst was noted and sample was sent for HPE examination, which was suggestive of ocular cysticercosis. And he was also sent for MRI brain to rule out any neurocysticercosis, but MRI brain was found to be normal, and patient was put on medical management, that is he was started on tablet albendazole 15 mg per kg per day, along with steroids, oral steroids 1 mg per kg per day, and he was for 1 month and followed up after 1 month, and there was resolution of the symptoms and signs. Here in the picture you can see the cyst on table. This is HPE examination. The slide was showing inflammatory cell infiltrates and consisting of eosinophilic lymphoplasmocytes, neutrophils and histocytes. So unique was when the patient came with a history of trauma, so we thought it as a conjunctival abscess or also hematoma, but for a surprise on the table it was noted to be cyst, and which HPE examination also supported the same, proving it to be ocular cysticercosis. And the take home message is that the early detection and treatment are crucial for preventing permanent visual loss, and imaging like CT MRI is essential to diagnose and localize the cyst, as clinical signs can overlap with other conditions. Cysticercosis should be considered in patients with endemic areas with unexplained ocular symptoms, and prompt action at the earliest can prevent long-term complications. And also focuses on good hygiene prevention, focus on good hygiene, proper food handling and controlling human tapeworm infection. Thank you.
Very good presentation, Dr. Ishwari. One thing just I wanted to add, because something which we routinely do is ultrasound. Was ultrasound done for this patient?
No, sir.
Because in myocysticercosis and orbital cysticercosis is very common in other ways, and it's a routine thing which should be done for picking up cysticercosis, which is located in the SRLPS complex, which is very common area. Other than that, it can also be found anywhere in the orbit as well. So preferably ultrasound is one of the earliest things which should be done, other than the clinical examination, and maybe an MRI or CT should be done afterwards.
Yeah, it was
Okay, ma'am, you want to add something?
Diagnosis you made before you took him up for surgery?
No, sir. Like he gave the history of trauma, so
No, what diagnosis you made?
Like we thought it as a conjunctival abscess, and we thought of
Conjunctival abscess, and it came out to be
cyst
where?
subconjunctivally, superomedially. The cyst was noted.
So that is what exactly is any orbital thing you have to image, you have to work up your patient well, you need to have some diagnosis before you take the patient for surgery. Because these are all well picked up on a simple imaging like ultrasonography or a CT scan or MRI, and all these facilities are available. So without proper workup, you don't take up the patient for further treatment. I mean, you have to have some working diagnosis. Second thing, you have said inadvertently maybe that subretinal cyst moved from the muscle. In the subretinal space, cysticercus, how does it reaches the subretinal space?
Through ciliary arteries it reaches. Circulation.
The lesion was outside the globe, right?
In general, she was describing the intraocular cysticercus is also there. You said that subretinal cyst, how does it reaches the subretinal area?
It is through ciliary circulations.
What?
Short ciliary arteries.
Okay. So you mentioned that through the muscle. All right. Okay. Anyhow.
So just one last word.
That's fine.
So the take-home message again would be that any of these trauma. In fact, I also encountered a patient who this child came with a similar subconjunctival mass, and the parent was so sure that they were they were playing with the balloons and with that toothpick that injury has occurred. So I thought maybe it's a foreign body that has led to a granuloma formation. The problem was it was so superficial that it would not be picked up with a B scan, so you need a UBM. And now how to do a UBM in a child? So I told them to get a CT. CT was not done. Even CT may not pick up, it is very superficial. So sometimes you do get into that dilemma, and actually the patient landed up finally with a huge mass and it was saying that I'm cystic sarcosis. They ultimately come like that. The important thing is that although most of these patients would be treated medically, but you must do a good indirect or ensure that there are no intraocular cysts before you start your albendazole, one thing. Other thing is the neurocysticercosis part has to be checked for before you start your course of albendazole, and be sure that you continue the albendazole should not be terminated prematurely. What I have seen is as soon as the patient starts recovering, they just stop the medication. So always keep a watch for the scolex to disappear, and then you have to terminate your treatment along with a cover of steroids. Anything else?
This cystic sarcosis is very common. It's not that it is uncommon. It's very, very common. 15 milligram per kg body weight is what you have said. Of a 80 kg person, what will you give?
450.
Albendazole, the dosage is, how much is the dose?
15 mg per kg
Per
body
kg
weight.
per day
DD.
in 2 divided doses? 2 divided or
Yes.
3 divided doses or a single dose?
2 divided.
2 divided. 80 kg person, how much dose comes? 120 how much comes? 120. And what is the tablet available? You have any idea? Albendazole? नहीं तो MBBS की बात
400
पूछ रहा हूँ.
mg.
400 milligram. So of a 80 kg person, you are giving 120 milligram per day. No, sorry, it is 15 milligram. 1200 milligram. 1200 milligram. So you will give 1.5. How much? 400 milligrams. One tablet 3 times a day. Have you ever explained to them?
Yes.
No, have you ever explained to them that when they go and buy the tablet from the market, the chemist will say that it is a single dose treatment? Because albendazole, for whatever purpose is given, it's single dose treatment.
Yeah.
And it is available in a single
Single.
tablet packing, isn't it, sir? So you have to really, this is practical thing I am saying.
Yes,
Many
yeah.
times patient goes to chemist says कि भी ये गलत treatment है, इतना तो dose होता नहीं है.
No, we have
Fine.
experienced that.
This is at MBBS level normally. Anyhow, thank you very much. Thank you.
Very nice
Thank you.
presentation.
Thank
Okay. So next up we have Dr. Juhi Arora. She'll be talking about. No, sorry. Tisha Vasant. Yeah. She will be presenting a case of Fraser syndrome. And Dr. Juhi Arora, please be ready for the next.
Good afternoon, everybody. I'm Dr. Tisha Vasant, and I would like to present a case on a case of Fraser syndrome. Fraser likes to hide but not seek, as I'd like to call it. Okay, so Fraser syndrome is a rare autosomal recessive genetic disorder that is characterized with features such as cryptophthalmos, syndactyly, malformation of the larynx and genitourinary tract, craniofacial dysmorphism, orofacial clefting, mental retardation, and musculoskeletal anomalies. Cryptophthalmos is a rare condition in which the embryonic lid folds fail to develop. The conjunctiva and the cornea are replaced by skin that lines the orbital margins. There are 3 types of cryptophthalmos, known as the complete or typical type, the incomplete or the atypical type, and the abortive type, which is also known as the congenital symblepharon. The patient who presented to us was a 9-year-old female presenting with the inability to close the eyelids and watering from the left eye since birth. On general physical examination, she also presented with low set ears, hypoplastic nasal alae, micrognathia, bilateral syndactyly, and ambiguous genitalia. On ocular examination, the right eye had a vision of 660 and the eyelids appeared normal. The conjunctiva also was normal. The cornea had total limbal stem cell deficiency and a macular opacity inferiorly. The pupils and the pupils anterior chamber lens were all good, and fundus was also, posterior segment was also found to be normal. And these are the keratometry values, which K1 was 45.5 and K2 was 49.75. and the refraction correction was +1 spherical and -2 cylindrical at 180 degrees. On the left eye, the vision was PL negative. The eyelids were presented with an upper lid coloboma and an ankyloblepharon. The conjunctiva, the cornea were all keratinized, and the rest of the details could not be made out, the anterior segment and the posterior segment. These are the photographs. The one shown on the top was the right eye, and the one shown below is the left eye. And these are the other pictures, like the other general physical examination photos, the micrognathia and the syndactyly. This is the post-operative photo. So this is a multi-step procedure which should be done for Fraser's, and this is just the first step which has been done up till now. We have only done a symblepharon release and a temporary tarsorrhaphy. What's unique in my case, Fraser syndrome is an extremely rare genetic disorder with an estimated incidence of 1 in 1 lakh to 1.4 lakh live births. As it is an autosomal recessive condition, it is more common in populations where consanguinity is more prevalent. Generally, this condition results in severe impairment of vision, but in this case, the right eye had a relatively better visual acuity, thus improving the patient's quality of life. The associated skin folds also provided a good anchor for the tarsorrhaphy sutures and also showed a little bit hope for the further steps in management, such as creating a conjunctival sac or a fornix also. Clinical implication, the significant vision loss is associated with this condition depending on the type of cryptophthalmus. Increased risk of infection due to defective eyelids as the protective mechanisms are also compromised. Psychosocial implications due to disfigurement and potential vision loss causing hardships in social integration. Monitoring and long-term care is often needed to tackle the complications associated with cryptophthalmus and other systemic abnormalities. Take-home message. The defects of Fraser syndrome requires a multidisciplinary approach to improve the patient's functionality and aesthetics. This case shows the need for early diagnosis of Fraser's in order to improve in order to prevent further keratoconjunctival exposure in cases of incomplete cryptophthalmos. This also shows the need for surgical intervention to prevent features of exposure keratopathy and reduce the risk of infections. Prosthetics also play an important role in improving the quality of life for the patient. No financial disclosures. Thank you.
Very nice presentation, Dr. Tisha. Just one thing I want to ask, you mentioned that the patient had ankyloblepharon as well?
Yes, sir. That was also like considered.
Usually, there's a stark difference between a cryptophthalmos and an ankyloblepharon. Can you just highlight it, if you can, if it's possible? Do you know what's the difference between cryptophthalmos and an ankyloblepharon?
Yes, sir. Ankyloblepharon is just where the eyelids are adhered. It was very laterally, so it. We didn't do an excision for that.
Is the lid formed or not in cryptophthalmos? Let's simplify the question.
Based on the type, ma'am, it is usually not formed very properly.
We're talking about your case. You mentioned there was ankyloblepharon. That's why he's asking this, because usually what happens is there is a continuation of the skin and the conjunctiva and there is no lid. So doing actually a symblepharon release was of no use. The cornea was already keratinized. If you really wanted to do a fornicel reconstruction, you need grafts and you need to reconstruct the lid. Doing a tarsorrhaphy will not help. So anyway, it is not your fault. It's okay. You just picked up the case and you wanted to show the findings, but that is not the way to go about. Okay. Right?
There's an obvious thing that there's a difference between the stage of development as well. Okay, there are 4 stages of development of eyelid.
Yes,
so what are the stages? Do you have any idea?
Yes, sir.
Fold formation, fusion, then separation, and lastly the maturation stage. So whenever there is a fusional problem or even the fold formation, that gives rise to an abnormality in the development of cryptophthalmos. Okay. However, when it comes to the difficulty in the maturation phase, when the separation is not completely occurring, where the lid is completely formed, otherwise the lid structure, the tarsals and everything, the mesenchymal tissues have already been there. Only there is some attachment between the upper and lower lid. That is ankyloblepharon. So ankyloblepharon can be of different types as well, I guess.
Yes.
So okay. So ankyloblepharon is a completely separate entity. Yeah. So that's why. Okay. Otherwise, nice presentation.
So take home is that for any postgraduate student, the diagnosis has to be well. You need to know all terminology. Fine. And in this presentation, when you were describing the clinical findings, there were no clinical photograph available to us to correlate those clinical findings. You just have shown one clinical photograph in the end. But whenever you're presenting something, all clinical findings, you at least have a photograph so that it can
Correlate and then you can
properly
make more
correlated,
sense.
so that you are clear and view. Anyhow, thank you very much. Thank you.
Thank you, sir.
Next, Dr. Juhi Arora. She will be presenting a case of Cruzen syndrome. We also have Dr. Akansha Bapnore. I'll ask that person. Okay, you're ready, right? Next, we'll have your presentation.
Good afternoon, everyone. I'm presenting a case of Cruzen syndrome. Cruzen syndrome is a genetically inherited autosomal dominant disorder, second most common craniosynostosis syndrome. First described by a French physician in 1912, Octave Cruzen, originally called it as craniofacial dysostosis. Cruzen syndrome is diverse in clinical presentation due to variability in craniosynostosis. The diagnosis may be missed in milder phenotypes and are thus prone for misdiagnosis. Gain of function mutation of fibroblast growth factor receptor 2 and 3 on chromosome 10 causes accelerated osteoblast differentiation, resulting in premature fusion of skull sutures. A 2-year-old male reported with chief complaint of bulging of both the eyes since the age of 9 months. There is no history of visual symptoms, any misalignment of the eyes or poor vision, no history of foreign body sensation or redness in the eye suggestive of exposure keratitis, no history of seizures or mental retardation or hearing loss. The prenatal, delivery and the postnatal history was found to be insignificant. Family history: non-consanguineous marriage, one sibling, elder sister not affected. He is the second child, mother affected in milder form, father and grandparents are not affected. Rest of the skeleton system was within normal limit. Developmental milestones are appropriate for the age. Examination: the baby was not cooperative for visual acuity evaluation, but refraction was done -1 diopter spherical in right eye, -0.5 diopter spherical in left eye. Frontal bossing, asymmetrical skull growth, increased intercanthal distance suggesting telecanthus 33 mm, and depressed nasal bridge with low set ears were present. Pupillary reaction, direct and consensual, both were present. Both eye, upper lid more than lower lid retraction present. On Hertel's exophthalmometry, right eye 21 mm, left eye 22 mm. Ocular mobility revealed intermittent exotrophy of 20 prism diopter with good control with V pattern and primary inferior oblique overaction. No lag of ophthalmos, no lid lag, and no signs of exposure keratitis. NLD passages within normal limit. Anterior segment within normal limit. Fundus no dyspallor extorsion. This is a picture of the baby showing upper and lower lid retraction, and mother picture showing unilateral lid retraction. Video of the baby showing intermittent exotrophia and X-ray skull showing fusion of metopic suture. Craniosynostosis syndromes may take time to manifest and therefore may be missed in early childhood. It is inherited as autosomal dominant fashion, but there is equal incidence of sporadic cases representing new mutations. The present case highlights this clinical dilemma: frontal bossing, misshapen calvaria, telecanthus, bilateral upper and lower lid retraction, along with V pattern intermittent exotrophia, highly suggestive of Cruzen syndrome. Hence, we report a milder phenotype, which may end up with wrong diagnosis. In the presence of bilateral upper and lower lid retraction, V pattern exotrophia, primary inferior oblique, common craniosynostosis syndrome like Cruzen should be suspected and evaluated by other clinical parameters and imaging. Within the family, members tend to have similar facial deformities but variable calvarial deformities, and this phenotypic heterogeneity makes it difficult to diagnose. The differential diagnosis may include thyroid eye disease, primary congenital upper eyelid retraction, dorsal midbrain syndrome, Apert syndrome, and orbital mass and tumors. In pediatric age groups, subtle forms may be missed or misdiagnosed. As a child grows, the typical features of Cruzen may appear and present with sight-threatening problems, so an early diagnosis is crucial. Thank you.
So, like in your case also, the differential diagnosis is orbital tumors. Did you imagine that patient?
So, but
simple, very simple thing. That is what I said in the initial phase also. Every orbital or anything you have to image and come to some conclusion. Textbook teaching is different. You yourself is saying, go back to that differential diagnosis. Look, you yourself is writing that orbital masses, orbital tumors is the differential diagnosis, isn't it? And that they need congenital malformations, fine, you may treat, you may not treat, but orbital tumors, orbital inflammatory diseases, thyroiditis, you need to treat them, and you have not worked this case up.
But sir, the mother was also
No,
having.
it is not but or if. You just look at the last of this. Orbital tumors, orbital inflammation is one of the differential diagnoses, and you have not ruled them out. And they need, if it is there, it needs a treatment. Otherwise, this child may not need any active intervention, isn't it? If the cornea is okay and accept the cosmetic treatment. So, working up of a patient, especially of any orbital disorder, proper workup has to be there before you proceed further.
Yes, thank you. Just one question. What is ureblefron? You have any idea? What is ureblefron?
It is decrease in the
Decrease.
increase in the
So did your patient
palpability.
have it? Have you seen any patient of ureblefron previously?
No, sir.
This is exactly a case of ureblefron. So the horizontal as well as the vertical palpebral aperture increases. It's typically seen in Cruzon. So just, I think you did not mention it in the signs and symptoms, so you just keep it in your mind.
Thank you.
So basically what, all through, it was quite evident that this is a craniosynostosis, but then, sometimes these imaging measures, they help you exactly what is the gravity of your, problem. Are you missing out on something? So one, I understand you are exposing the child to radiation. So sometimes we think why to, get a CT done. But at times it is, if you're in doubt about anything, it is better to get a imaging done and take your measurements properly. That's all. Thank you.
Next, we have Dr. Akansha Bapnore. We also have Dr. Kunal Singh, right, with us? Yeah. Maybe next you can present your slides as well. Okay.
Good afternoon, everyone. Today I am presenting a very unique case with the title Tears of TB. So, 39-year female patient presented to our OPD with a chief complaint of swelling in the lateral aspect of right eye upper lid since 1 month. The swelling was insidious in onset, gradually progressive, and was associated with mild pain. The patient is diabetic, on treatment since 1 year, and no other significant history was present. On ocular examination, we found 6/4 mm swelling in the superolateral aspect of right eye upper lid. On palpation, it was firm with smooth surface and mild tenderness was present. Finger insinuation test was negative and no other positive findings were present in anterior or posterior segment. So further, we did CT scan orbit in the coronal and axial section, and we found that there was a diffuse enlargement of right eye lacrimal gland which was heterogeneous in attenuation with small ill-defined hypodense areas associated with fat stranding in the adjacent extracorneal fat and with mild preseptal edema, which was suggestive of inflammation. So further, we managed the case with right eye orbitotomy with excision biopsy of the mass under general anesthesia. On histopathological examination of the same mass, we found granulomatous inflammation with necrosis suggestive of tuberculosis. There was no acid-fast bacilli present on special stains, but the mycobacterial tuberculosis cultures were positive. As well as on further investigations, Montux also turned out to be positive. ESR was raised, and for other foci of infection, chest X-ray and USG abdomen was done, which was normal. So final diagnosis was based upon histopathological and all radiological examination that it was primary tuberculosis of the lacrimal gland. So further, with the reference to the chest physician, we started the patient on anti-tubercular therapy. For intensive therapy was given of HRZD for 4 months and for the continuous therapy for 2 months. There was no evidence of recurrence after the treatment, and in the regular follow-up visits, the ESR was also coming down to normal. So orbital TB may involve soft tissues, lacrimal gland, periosteum, or bones of the orbital wall. Intracranial extension can also occur in the form of extradural abscess, or infratemporal involvement can also occur. Tuberculous dichoroidinitis is an extremely rare manifestation of tuberculosis. The clinical presentation and gross appearance of tuberculoma of lacrimal gland can be similar to other benign mixed tumors of lacrimal gland. So histopathological examination plays a key role in differentiating swellings of infective and neoplastic etiology of lacrimal gland. Thank you.
I asked the question again. What was the diagnosis you made before you took this patient up for surgery?
So we considered DDs as one of as lacrimal gland tumor.
So in the first diagnosis you made was lacrimal gland tumor.
Said there was fat straddling and so much of
So before radiological examination, we considered
No,
it as
I'm saying once you took the patient for surgery, with all investigations available to you, the first diagnosis you made was considered was
benign
lacrimal gland
tumor.
tumor. And what was the plan for that?
So because we didn't suspect
You were to plan the whole of the lacrimal gland in toto, or you were again subjecting it to the incisional biopsy? What surgery you did?
So we did excision biopsy because on
Excision
radiology.
biopsy.
Yes, sir.
How
Because on
large was the mass?
Around 6/4 mm.
Mm.
Yes.
For that you needed GA.
So because the patient was not cooperative, that's why. Otherwise we had consulted for local anesthesia.
So actually,
Because
the whole
these are
is a
serious
little-
issues. This is not a simple. This is not joke. These are very serious issues. Lacrimal gland inflammation, masses, they are serious issues. You actually need to know what you are doing and why are you doing it. If you had confirmed your diagnosis to be lacrimal gland tumor, which type, and accordingly you plan, because if you are just simply going there with the diagnosis of lacrimal gland malignancy and you making a nick there and coming out and waiting for the histopathology report, that is not a way the lacrimal gland masses are managed.
So because on radiological
What
examination.
was the age of the patient?
34.
34 years. So what would I think let's reverse the order and ask what would be the causes of lacrimal gland enlargement in a 34-year-old patient?
Pleomorphic adenoma can be one of the DDs.
So does the pleomorphic adenoma present like this? How long was the duration of the mass?
1 month.
1 month. So it's a short history. Now you
Yes.
yourself giving the clues. It's a short history. Was it painful?
Mild pain was.
So there is an inflammation. So the question of tumor does not arise in the first instance. It is inflammatory mass. So you simply need to rule out the causes of inflammation. So what are the causes of inflammation now?
Like sarcoidosis can be one of the reasons.
Or common?
Infected dermoid cyst can be one of the reasons.
Lacrimal gland की बात हो रही है ना अभी? और
Dacrodenitis.
वो तो
Infective
हर
dacrodenitis.
inflammation को
Infective dacrodenitis.
और क्या होते हैं? कॉमन चीजें बताओ ना. ट्यूबरक्लोसिस तुमने बता दिया, चलो माना. IgG4 को रूल आउट करो, sarcoidosis को रूल आउट
No,
करो.
the workup is absolutely essential, because on that basis only you will go ahead.
You don't need to jump
go
GA
surgery
देके
is
उसको
not
pa-
hard.
it made
You
no
have to have a
sense.
reason why are you doing it.
चलो कोई बात नहीं.
वो तो
Good
fortunately you came out with a tuberculosis. और उसमें भी फिर then in the retrospect you did ESR, you did this or that. Isn't in a retrospect? क्या भी tuberculosis आ गया है? और अब इसमें let us prove it कि yes, it is actually a tuberculosis.
So because it's very rare, so we didn't
No, it
consider
is not
it in
that
the
rare.
first.
No, it's not that rare. And anything which is, those fat straightening, these are signs of inflammation. So you just cannot afford to say कि ये rare था और ये, so this is a messed up plan of action.
Actually, ma'am, before radiological examination, we considered tumor as one of the
बच्चे
DDs.
अब हमने पढ़ा दिया, अब जाके घर पे किताबें
See,
पढ़
we
लेना.
are
चलो,
just giving
thank
you a message as a postgraduate students and future ophthalmologist. I mean, all are future ophthalmologists, good ophthalmologists. Work up your patient well before you start managing treating surgically or by whatever. You have to have some working diagnosis to work on. Nothing can be random. Any orbital thing, always imagine well, always work the patient very well. Like that sarcoid patient, that is ideally it should go. One by step. You find something, you try to prove or disprove that, then go to next. That is how you
एक पूरा
manage.
चैप्टर है
सब
ऑर्बिटल
कुछ work
इन्फ्लेमेटरी
होता है.
डिजीजेस. आज जाके रात को पढ़ना.
ऐसे ही
चलो
होता है.
उठो. नेक्स्ट को भेजो सर.
Thank you.
Dr. Kunal, Dr. Kunal will be presenting a case of supraorbital mass, TB osteomyelitis. Okay. And next, Dr. Abhijay Luthra's, I think he could not make, and so we'll play the video.
Good afternoon, everyone. Title of my presentation is When a Supraorbital Mass Reveals a Deeper Truth, that is TB
We can't see the
osteomyelitis.
slides. Can we just?
Skeletal tuberculosis account for 1
wait,
to
we
3%
can't see the
of
slides.
total
Just
cases.
wait.
Just wait.
Slides for
Slides are not on. Okay, fine.
Skeletal tuberculosis accounts for 1 to 3% of total cases of tuberculosis, out of which 0.2 to 1.3% involve the calvarial bones, thus making it extremely rare. Orbital TB is more common in children with a higher incidence in females. It typically presents gradually and is usually unilateral. Our presentation focuses on a patient who presented with a complaint of mass on left eye following trauma. Initially, the mass was suspected to be a result of trauma itself. However, upon further investigation, imaging studies and histopathological examination, it was revealed that the mass was caused by TB osteomyelitis of orbital rim. This case highlights the importance of considering TB osteomyelitis in the differential diagnosis of orbital masses. The patient was 22-year-old male with chief complaints of swelling over left eye since 6 months. Patient was apparently well 6 months back when he had trauma to his forehead by gate of a bus, after which he developed swelling over his left eye, which was progressive in nature. On questioning, he gives a history of a fever, which was on and off. He also gave a history of TB contact and history of loss of appetite. The swelling was not associated with pain. There was no history of bleeding at the site of trauma, no history of diplopia, no history of an increase in swelling on coughing or sneezing. On examination, the general physical examination and systemic examination of patient was within normal limits. Visual acuity was with glasses was 6/9 in both eyes. Lids and adnexa were within normal limit. Anterior segment findings were unremarkable. On inspection, there was a mass of size approximately 20 into 15 mm on superlateral margin of left eye. There was no change of skin color, no dilated blood vessels, and translumination test was negative. There was no increase in size on Valsalva. On palpation, the mass was firm to hard in consistency with well-defined margins and smooth surface. The mass was non-mobile and non-tender. There was no local rise of temperature. On auscultation, there was no evidence of any bruit. On presentation, the patient had a mass on superlateral part of left orbit, and the NCCT of the NCCT head of patient also showed a hyperintense lesion on superlateral orbital rim of left eye. On investigation, patient came out to be Montaux positive, and his chest X-ray also showed blunting of costophrenic angles and increased bronchovascular markings. Patient was then referred to pulmonary medicine, where his pleural tap was done. Pleural fluid was sent for cytology and biochemistry examination, and the findings were suggestive of tuberculosis. So he was started on anti-tubercular therapy. Follow-up after 3 months showed resolution of the mass. Clinical implications. Given the complexity of the case, a multidisciplinary approach involving ophthalmologist, pulmonologist, infectious disease specialist, and radiologist is crucial in managing such patients. The orbital mass and pleural effusion were important clues that led to the identification of TB as the underlying cause. The take-home message from this presentation is early recognition and appropriate management are critical in improving outcome for patients with TB-related osteomyelitis. I would like to express my deepest gratitude to my professor Dr. Anuj Mehta and my senior Dr. Gajashri. Thank you.
So after how many days of trauma did the patient present to you?
Ma'am, patient had trauma 6 months back, so he came after 6 months.
After 6 months.
Yes,
So what would be your differential diagnosis once the patient presents? Let's now start working like this.
Ma'am, our first differential diagnosis was a hematoma.
Okay.
And it can be also a dermoid.
Okay. What dermoid? What happens to the dermoid?
Ma'am, there is lipogranulatous inflammation.
No, I'm not asking the histopathology. Why do you think the dermoid patient would present at this juncture?
Ma'am, because there is the dermoid usually present on suture lines. So there is zygomatico
so what
frontal
happens after trauma?
Ma'am,
Dr. Salim, मेरे पास time है नहीं तो मैं छोड़ दूँ इनकी.
Because of trauma, there is release of the
So
Yeah.
a ruptured
Rupture-
dermoid
rupture.
can suddenly start, causing a concern. Otherwise, the dermoid was always there. It was nothing de novo that had happened.
Yes, ma'am.
Okay. और क्या हो सकता है?
Ma'am, any AV malformation.
Okay.
And ma'am, schwannoma.
Schwannoma, सीधा.
Post-traumatic schwannomas, like we are going to correlate to something with the history of trauma.
Yeah.
So something which is either existing beforehand, after the history of trauma had aggravated, or something to begin with occurred after the trauma. Like in this patient, you had diagnosed eventually tuberculosis, right?
Yes, sir.
So anything else other than that we have discussed?
So related to this history.
Yeah.
So there could be just a foreign body somewhere. It would have entered, formed
But
a granulomatous reaction can occur if there is a breach on the skin.
Ma'am,
If there is a breach.
but the patient did not give any history of bleeding from site of the trauma.
Okay.
So
And what do you think? What are the other presentations of tubercular osteomyelitis like this?
ma'am, there can be a draining sinus.
Okay, discharging sinus.
Yes, ma'am. And if the TB spread to the inner table of the skull, it can involve the dura of the brain, and it
Did
can.
your patient have fever or anything else?
Ma'am,
Why did you think about pleural effusion? Did he have any systemic
No,
examination?
ma'am. He gave history of fever, which was on and off, history of TB contact, and history of loss of appetite.
contact तो सबके ही हो रहे होंगे
Yes,
contact यहाँ पे इंडिया में. वो तो that is not significant. What really brought you, what really you have to evolve the patient. It is just that you found that.
Ma'am, we did investigations which were like raised ESR and raised TRP. Also, patient was Montux positive. We done the chest X-ray.
सबके चेस्ट एक्सरे थोड़ी ना कराते हैं ना, कुछ तो कारण रहा होगा ना.
Ma'am,
और दूसरा, जब भी कोई इमेजेस दिखाते हो केस प्रेजेंटेशन में, तुम्हारा ऑर्बिट तो नहीं दिख रहा था, सब कुछ दिख रहा था. So these sessions are just to make you evolve into a better presenter. जब तुम हमारे तरह बूढ़े हो जाओगे तो you should be better. So that is the only idea of presentation. ठीक है, हम तुम्हारी कोई टांग नहीं खींच रहे. हम सब छोटे थे, हम सब ऐसे ही थे. So next time you present your scans and everything, they should be bold and large. तो उसमें तुम finding दिखाओ. तुम्हें अगर तुम स्कैन देखते ना, उसी में तुम्हें क्या होता, अगर सपोज इट्स ऑस्टियोमाइलाइटिस, क्या दिखेगा स्कैन में, बताओ.
ma'am, hyper intense lesion, like
क्या होगा बेटा, स्कैन देखे थे आपने?
there can be a sequestrum within the bone.
बोन देखी थी, उसकी बोन दिख रही थी उसमें तुम्हारे स्कैन में?
Yes,
या नहीं
ma'am.
दिखी थी?
Yes,
क्या
ma'am.
दिखा था कुछ?
You should try to zoom it possibly.
कहने का है कि भी
Try
अच्छे
to-
से प्रेजेंट हो ताकि पता रहे कि भी हाँ this is exactly.
The area of concern should be zoomed in and possibly
ऐसे
highlighted
कुछ
in a
पता
better
होता
way.
ना तो बात थी. खैर anyhow,
Yeah,
you're
you-
lucky that you found pleurisy there,
Pref-
and they could tap and they could come to some diagnosis, and you could save this by just systemic treatment. Otherwise ये ना होता तो शायद आप लोग भी उसमें.
एक्चुअली ट्रॉमा वाज जस्ट जब भी हिंदुस्तान में कुछ होता है, वो कोई एक घटना के ऊपर, जैसे कोविड के इंजेक्शन से बहुत बीमारियां हो गई लोगों को, जो कि कभी नहीं हुई थी.
She's
You know,
right.
Ma'am, there was one case of just a 14-year-old girl also, which also had history of trauma. Then she developed swelling which related to TB osteomyelitis.
It may not be
So
what
why-
ma'am is
why-
trying
no,
to say is
why-
that
let him work on it. Why do you think that trauma precipitated it? Why do you think?
Ma'am,
अरे कि हड्डी में कुछ कमजोरी रही होगी ना, तो वो ये भी तो पॉसिबिलिटी है. इट वाज ऑलवेज देयर.
yes, ma'am.
It was always there. The attention was focused on it after the trauma. ये trauma से osteomyelitis नहीं होता. Rest assured, be assured कि closed wound injury में कोई ऐसे चोटें लग के osteomyelitis नहीं होते. But वो पहले से था तो वो expose हो गया. आगे समझ में बात?
Yes, ma'am.
the lateral wall is one of the very common areas for the TB to get involved. Tuberculosis is a very common site. Is in fact on the orbit, it's most commonly involving the lateral side. So that is one of the key points take
ट्रॉमा
should
में
be.
भी जैसे मैम ने पॉइंट आउट किया, इट इज नॉट एसेंशियल दैट यू गेट अ हिस्ट्री ऑफ पेनिट्रेटिंग इंजरी, फाइन, और अ वुंड और अ स्कार. वी स्टिल सी wooden foreign bodies impacted there after months initially, because when you fell down on a road, many things can happen. Anyhow, thank you.
Thank you, sir.
So we'll have the last video presentation. I think the person is not here, Dr. Abhijay Luthra, and I'll also request the presenters to be here. Maybe we'll take a photograph after this slide.
And you can ask us some questions. We have been pulling your legs, you can pull our legs. We're okay with it.
And Abhijay Luthra.
This is not a pulling of legs. This is just to,
भाई सर हम तो मेडिकल कॉलेज में यही करते हैं सारे आदत है
it is only that we just trying to emphasize that take up for the presentation only those cases which you have handled yourself, so that whenever any question is asked during these presentation, if they were your own patients, you know them on tips. Okay, yes, this is what was happening, because these are long patients, no? For months together they stay with you. Fine. And बाकी तो सब ठीक है, all papers are good. You have presented good papers, good findings, all good. And this is the last video.
The person is not here, so we'll play the video, recorded video.
Hi everyone. I'm Dr. Abhijay Luthra, and today I'll be presenting on reviving tradition, frontalis muscle flap advancement for simple congenital ptosis correction in a child. So our patient was a 12-year-old male who presented with complaints of drooping of the right eye upper lid since birth, non-progressive in nature, and he had a visual acuity of unaided 6.6 in both eyes. Here is a representative image showing the right-sided ptosis. On ocular examination, he had free and full ocular movements in all directions and a palpebral fissure height of 7 mm in the right eye and 9 mm in the left eye. MRD1 and MRD2 were +3 and +4 mm for the right eye respectively, and the patient had a poor levator action equivalent to 4 mm in the right eye with no lag of thalamus. The findings in the left eye were within normal limits. The patient did not have any Marcus gun jaw winking, Bell's phenomena, corneal sensations were within normal limits, and frontalis overaction was present on the right side. So we came to a diagnosis of right-sided simple congenital ptosis with poor levator function, frontalis overaction, and chin-up position. So we decided to go in for surgical correction, and our three options were levator resection, which was not suitable due to poor levator function, tarsofrontal sling, which is usually done for such patients, but it needs a foreign material implantation. We decided to go with the frontalis flap advancement, an unusual approach in which there is no need for a foreign implant. There is direct harnessing of the frontalis action. Going on to the surgery, first of all we start with a lid crease incision, and a dissection is done. Using cautery, all the structures are separated, and we first of all try to isolate the frontalis after going through the preaponeurotic fat. And here, here we've got the frontalis muscle. So what we're going to do is we're going to create an aponeurosis between the frontalis muscle, the levator aponeurosis, and the tarsus, and thus we're directly harnessing the action of the frontalis to the levator and to the tarsus. After meticulous suturing in separate layers, the eye is closed and the extra LPS is resected, following with the eye is closed. So the surgical procedure was completed, and on post-op day 1 the patient had a outcome with a vertical palpebral fissure height of around 9 mm, lag off of 2 mm, and mild lid lag present. At 1 month post-operative, the patient had a good correction with a lag of thalamus of 3 mm, but there was no corneal exposure on closing the eye. Patient had mild lid lag with a good lid contour. So we were happy. Our mission post-op, our mission was accomplished. So frontalis flap was first introduced in 1901, and moving on, so it's mainly indicated for patients who have poor levator palpebrae superioris function or have undergone a failed prior levator advancement procedure. The main advantages are that it avoids implant-associated risks such as extrusion, infection, or granuloma formation. It's an aesthetically pleasing eyelid crease incision, avoids autogenous draft donor site morbidity, and can be performed at an earlier age than autogenous graft sling surgery. The disadvantages are as mentioned below. Some of the potential complications are lag of thalamus, entropion, and eyelid lift-off. So in conclusion, it's an effective tool for the correction of ptosis. Thank you.
So just a word, I think this surgery is still under evolution. We have all been doing studies. ये आपको अभी छोड़ दो आप.
छोड़ दो.
समझ आई वैसे अगर in case you want to ask, she is the authority on this particular topic. She has done lot of work on this, lot of cases on this. In case about this frontalis sling surgery.
So I
This
think
one.
for your
आप-
level,
हाँ,
sir, for
पूछना
your
तो
level,
पूछ लो, हाँ.
for your level, the only thing is in an exam, if somebody asks you in a patient with severe ptosis with poor LPS action, what are the different alternatives that you have? So you can mention silicone sling and you can also mention frontalis sling. I think that's it for your end.
हाँ.
That's it. फिर जब आगे बढ़ेंगे फिर बताएंगे.
चलो आप आ जाओ सब photographs के लिए.
Thank you, ma'am. Thank you, sir. So I'll, yeah, very good.
Presentations, keep working well.
Few things I just wanted to highlight. I think most of you are making the slides possibly for like these are the early phase of making slides. So I did see multiple spelling errors as well. I will not point out who it was. So I guess a few people already know it. So please make sure that you don't have any obvious spelling errors, and not just that, even the content when you're putting, just keep in mind that the words should be limited so that one can, the person who's also sitting and judging you, or not just judging you, to whom you are presenting, can read through it. If you have too many texts throughout the slides, each and every slides, few I saw that there were more than 20 lines or something, but preferably the font size should be bigger, and try to keep it limited so that every time you utter a sentence, it's highlighted and it's get registered into the person whom you are trying to reach. Okay. Otherwise, it was very nice.
And no photograms from the Google. No photo. Your own photographs. He has shown 2-3 photographs from the Google. So
And your scans, please smudge the patient, identification numbers and names. That is very, very important. Because all these are getting recorded, they'll go on the website. So anybody can come and sue you. Yeah, why are you showing our images?
You should always have an informed consent form for that also, for presenting anything. Yeah.
yes, this we missed.
Yeah.
None of you had mentioned that you had the consents. The first slide should be comprising of this, that you have the consents available. For any presentation, you have to have the consent. You know what is consent? Have you ever taken consent, or somebody else takes the consent?
So I think they do. They are not. They are not MBBS students. They are practicing ophthalm. So I think.
No.
I think they are
this is
learning
important
ophthalm.
thing. Just off track.
Okay.
There are
Consents.
dedicated case report journals also. They have a very specific informed consent when you are publishing a case report. And they don't even like to say it was a girl or boy this many years. They will say it's a adolescent. They would write words so that the identity of the patient is not
compromised,
disclosed anywhere. Until unless, of course, the patient has given complete consent, and it's okay.
Yeah. And even in this, when you are mentioning slides of CT scan or MRIs, the data even there is also mentioned. The name and age of the patient is usually mentioned. So you should try to blur it, crop it, or whichever way you find it doable, you should be doing it. Okay. Yeah. So next, I think we can call everybody for
Please. It was wonderful. We all learned from you.